Let me push the button to go live.
Okay.
Can someone quickly check on the channel if it's working? Looks fine on mine. Let me push the button to go live. Push the button to go live.
Okay.
Why am I hearing myself
Can
3
someone
times?
quickly check on
Here we go.
Someone quickly check on the channel if it's working?
Looks okay. Brilliant. All the echo is gone.
I must apologize before we start. I have the dog with me.
That's fine. I always have a dog with me.
Yeah. If anyone comes down. If anyone comes through and he barks, it's just my lovely.
Don't worry.
I've got lots of treats, so
we are very inclusive, including pets.
Yeah.
Right. Okay. You can see the screen. Now, it's my absolute pleasure to have Elina here with us. She has a degree in clinical psychology from the University of Athens.
Found that.
Then segued into speech and language therapy in London, and then topped it off with a PhD in neurological studies from UCL, the Institute of Neurology, where she investigated speech changes after deep brain stimulation for patients with Parkinson's and dystonia. Now, I had the great pleasure to meet her in Greece last year, and I was absolutely amazed by her presentation and the work that she's doing. And not only does she do important work in the speech and language therapy world, but she also is a founding member of the Sing for Joy choir in London for people with motor disorders, also including the helpers and carers, and of course, expert teachers. So without further ado, I give the floor to you, Elina. Thank you for being here.
Thank you very, very much for inviting me. And boom. Yep, we'll get through it. So I'm very, very happy to be speaking to you about speech. And this is a quote I like because it does stress two things that we're still trying to do: the physiology, trying to localize speech, and trying to use physiology to localize speech, but also the fact that it is a grand attribute of humanity, as Bateman told Broca back in the 1870s, when they apparently had a logomachy, a fight with words. So we're going to talk about the motor aspects of speech, not so much the conception, the language aspects, but just the motor aspects. So how we speak, what can go wrong, and ways to fix it. But I'm going to stress Parkinson's and extrapyramidal disorders because that's the title of the talk. There is a very, very nice project. We are contributing soundvoice.org, where the effect of voice problems and speech problems from all sorts of cancer or neurological disorders affects everyday life, and you can find more about that if you click. Now, before we start, I'd like to, it's a kind of hobby that became obsession, voice recordings. Voice recordings started back in 1877. So before Thomas Edison, we had no way of keeping a person's voice in our memory. And with all these voices everywhere we have today, and the immediate way of playing back anybody's voice, music or anything, I think it's good to go back to the to think of the times where we didn't have this ability. And the reason I'm obsessed with it is because all the work I'm going to show you is partly based on the accuracy and the precision of these voice recordings. And for us, it's almost as important to have it right as, for example, if you get a blood test, if you take a blood test, you need to have it properly sterilized, properly in a proper procedure to get the proper outcome. So a voice recording started 1877 with a wax phonograph, but then it became obviously electric 1920s. We have ways to record baboons and lions for the MGM movies, if you remember. But the way to record people with movement disorders has recently been established and consolidated through the work of my wonderful colleagues in Prague, in Charles University, Professor Jan Rouge, who is a pioneer really in solidifying the way we record and analyze speech. This is one of his slides, and I'm very grateful to him, where I'd like you to listen to a healthy speaker first, and then a person with Parkinson's, and try and decompose in your mind the speech. It's a Russian sentence, so it's easy if you don't speak Russian to think of voiced, unvoiced, breath, and pauses. So decompose this speech in terms of these elements, and think of how they interplay in healthy and unhealthy. And even if we don't go into this specific, think of when you hear back, if you ever play back an audiobook or an article in the paper where it's got the option to play back, think of when you really know when it's a machine talking or when it's a person talking, and what makes that difference. So this is interesting, just as a encyclopedically.
Když člověk poprvé vsadí do země sazeničku, chodí se na ní dívat 3krát denně, tak co, povyrostla už nebo ne?
That's PD.
Když člověk poprvé vsadí do země sazeničku, chodí se na ní dívat 3krát denně, tak co, povyrostla už nebo ne?
And that's only the voiced elements of speech.
Když člověk poprvé vsadí do země sazeničku, chodí se na ní dívat 3krát denně, tak co, povyrostla už nebo ne?
Unvoiced, so p and t. And that's the breaths. And finally, the pauses, which are not audible. So you see, all of this is coordinated without thinking. That's the other magnificent aspect of human. Now, I hope this plays, but these are the vocal folds that we need in order to voice. Let me see the... So we were supposed to see the spectrogram here, but it doesn't show. But just to imagine, we've got the vocal folds here behind the Adam's apple. And if you want to try it out and do, say, and check out how the z sound, for example, it's got the vibration in the vocal folds, whereas it's got the tongue in the same position, but no vibration. So they're absolutely necessary in order to get the voice, the sound. And then we've got another video. I hope it doesn't show, but that was another example of how we coordinate now, not just the voice, but also the p, the t, and the k sounds, the tongue aspects. Moving on, these are the guidelines we published recently with Jan, so that we make sure studies, when they involve acoustic measures and voice, have a protocol to follow, just as a guide. It doesn't have to be followed, but it would be nice. And this is just a diagram from my favorite studies of Ackerman and Ziegler in early 2000, where they try to pinpoint how we speak. So we've got, if you try and say speaking and think of where your tongue is and where your lips are and where the voice is. So you've got the lips for open, but the tongue tip is moving when you say behind your teeth. And then for the E, you've got the voice, the vocal folds, the vocal tract working. And when you go for k, you've got the glottis, the back of the tongue, and so on and so forth. So this coordination happens with the aid of cortical and subcortical structures, and obviously the nerves and the nuclei. This is 42 nerves, muscles involved in the coordination of speech sounds, so that we produce about 16 to 18 sounds per second. Any more, and it's too fast for us to process, and much less, say 10 to 8 sounds per second is too slow, so that we forget where the person started from. So this neural control has to be very precise for our auditory system to process as well. This is from Jürgens, another wonderful researcher who analyzed muscles and nerves involved in speech. And I like it because it's really wonderfully structured into respiratory muscles, laryngeal and supralaryngeals, the 3 levels that interplay in order to get a clear speech. However, we do have some animal models recently, and I'm going to present a few of them because they're good fun. We also have lesion studies, but very, very limited imaging data, partly because of methodological problems and artifacts. So this is one of the issues in our area, lack of imaging data, we are trying recently to bypass that by Narayana. I'll tell you later. So animal models and speech. We have zebras, songbirds, and this is a couple. The male is the one that has the zebra lines, and the female is this one. The male has about 12 utterances, and the wonderful thing about these songbirds is they learn these 12 utterances when they are babies. They have a critical period, pretty much like humans. And this is wonderful because they learn the utterances, not that they were born from the family they were born, but the family they're adopted by. So they have the ability to learn, motor learning for singing, similar to humans. But if you look at the chicken, for example, that does ko-ko-ko, has no ability to learn any ki-ki-ki, and the same for the macaque. So we managed to divide vocal learners and non-learners. In the vocal learners, we've got bats, and they're wonderful models for vocal learning. We've got whales, we've got elephants, and obviously humans. But the difference between the two is the links between the cortical and the subcortical centers and the nuclei. So in the chickens and the macaques, or the non-vocal learners, we don't have this link between the cortex and the brainstem and the motor nuclei for speaking. Whereas, for example, in the songbird, sorry, let me go back, just because I love these songbirds. The Moorman study is wonderful because they manipulated the cortical and the subcortical links, and they got the birds to stutter, to get less variable singing, and with blocks similar to human stutter. And we get back to stuttering a bit later. We also have the singing mice, who are known for their conversations, and these conversations are very, very timely and pretty much like human conversation, and they interact in a wonderful way. There is also a video in this one. And this timing of interaction, this vocal control, voice onset timing, is disturbed when they manipulate the cortical and subcortical interactions. This is why I'm so happy to be presenting on basal ganglia Parkinsonian speech problems, because this is exactly the human analog of this disturbance of the cortical subcortical interactions. This is a very, very brief slide, and I apologize because you're probably interested in imaging, but I thought maybe this talk should be more about speech and videos, partly because we have very little data on imaging and healthy speech. This is the study I like the diagram of, is by Soros. And I like it because it's got the basics of initiation, execution, limbic and emotional aspects of speech, and the final motor nuclei for speaking. It also has, it doesn't have everything there, but it does have the main center for sensory motor integration, the auditory, main auditory sensory motor integration that we absolutely need. And I'll get back to that later. So that's just a summary of all this neural control information, and I promise to go to videos and more practical things after. But briefly to say, this is from Simonian's article in 2016, and to summarize, we can think of speech, motor speech control, as based on 3 subsystems. The basic one is the coordination of laryngeal, articulatory, and respiratory activity. And then we have subsystem 2, where we include the emotion and the variability and the melody of speech. That's what's lacking, for example, from technical speech reproduction. And then we have the voluntary vocal motor control, the control of when exactly we want to talk, when we have a conversation, for example, when we want to say something. A wonderful example of problems with that is when you say a joke, when you really need to be there at the right time. It's pretty much controlled by the cortex, that initiation of vocal timing. So this is the clinical aspect, and this is the part I like most. The framework for working with motor speech disorders is not always simple, because we have many points of view that we have to link. One is the neurologist, and they're usually interested in the phenomenology and whether it's consistent with the diagnosis. Then we have the basic scientist, interested in the mechanism and details of the mechanism and how they interact. We have the rehabilitation worker who's interested in how to move forwards and how to assess the life, the problem, the speaker, and bring things together, but to move forward. And then we have the speaker who's got a journey in a chronic disease, usually when we talk about extrapyramidal disorders. And it's always interesting which stage of their chronic disease we're plugging in, with appearing. And the mechanism, they've got mechanism there for coping. Also, the priorities for the communication are important. The reason I put this slide on is 1969, and it feels dated. There is a Duffy book, which is a Bible, and the Duffy book is 2020. But the majority of the studies are and the knowledge we have is consolidated in the Daly, Aronson, and Brown from the Mayo Clinic work in 1969, where they recorded about 30 patients from each major disease, and they described in great perceptual terms. So nothing to do with acoustics or nothing to do with numbers, just how it sounds. So they described the speech of these patients, and then they tried to link with the pathology. The idea and the aim and the ambition is still to link pathology and neural pathology with what we hear. And that's been a dream to localize, as Broca said to Bateman, or Bateman to Broca, the grand attribute of humanity, the faculty of speech. So this is where we started. And I wish I had the time to show you a little bit how, for example, flaccid dysarthria sounds. So dysarthria that is caused by damage in the lower motor neurons. Or I may play you, let's see if that plays, for example.
Yes.
No, it doesn't move. The videos, I don't know why. So this is a patient with MND. We could get back to those after. Maybe we could do spastic dysarthria. We'll have a couple with extrapyramidal. This is multiple sclerosis. Let's see if this one plays. This one is not particularly interesting for the speech because the patient is anarthric, but it's interesting for the way we communicate, and that's through eye movements. So the only movement we had to use for communication were the eye gaze, and this is one of the ancient ETRAN frames, which is based on alphabet and colors. I could play. If it plays, I'll be so happy. But
Okay. So, Claire, I don't think we can. So I could look at these systems and see how we're using it. Yeah, it's something that
it doesn't move, but just to say that he needs to look at the corner and then look at the color. So if he looks here, the green color, and then he looks at green corner. I may get back to it after, but it's C. So this way, each letter, if he looks at here, and then he looks at blue or black or red or yellow, then I know which letter he picks, and we construct the sentences. So it takes about, this one is 2 minutes to say a sentence, like I like swimming. It's not so automatic as it shows with, for example, the Stephen Hawking's machine, but the eye gaze machines are really, really, really hard to train and very hard to use. This is one of the best ones I had, and I still have, and I use with people who are anarthric and have limited movement. Yeah, I used it similar to Stephen Hawking's, but it's not so easy as it makes, as they make it look. So we're going then to basal ganglia in speech, where the videos will work, I hope. But the evidence we have for what we need basal ganglia for, and by basal ganglia we have subthalamic nucleus, one of these lovely little nuclei in between thalamus and globus pallidus. We have globus pallidus internum and externum, putamen, and PPN, zona incerta, which is a bundle of fibers that goes from the cerebellum all the way up to cortex, and then we have the internal capsule. We have some evidence from pathology, mainly the stuttering pathology, that basal ganglia are involved, spasmodic dysphonia, or laryngeal dystonia, as we recently call it now. And we also have evidence for the link between putamen and pallidum on timing of articulation for the slow rate and of speech, and generally the basal ganglia role in the execution loop. But what we mainly have is patients' recordings and patients' speech from Parkinson's disease, from dystonia, from neurologic stutter, so disfluencies, and all the other PSP, MSA, Parkinsonian syndromes. I'm going to concentrate on patients with Parkinson's for this talk. So we have, so far we thought it's a speech problem comes with longer disease duration, but studies from Jan Rouge's group showed that we can have speech problems in early de novo patients who haven't started any pharmacological treatment yet. So have a look again at this video. This is healthy speech.
Když člověk poprvé vsadí do země sazeničku, chodí se na ní dívat 3krát denně. Tak co? Povyrostla už nebo ne?
Když člověk poprvé vsadí do země sazeničku, chodí se na ní dívat 3krát denně. Tak co? Povyrostla už nebo ne?
Now, this one, I want you to listen to the difference between the two you've heard and this one.
Když člověk poprvé vsadí do země sazeničku, chodí se na ní dívat 3krát denně. Tak co, povyrostla už nebo ne?
So you saw, I hope you heard how it wasn't just monotonous, it also had a weaker voice.
Když člověk poprvé vsadí do země sazeničku, chodí se na ně dívat 3krát denně, tak co, povyrostla už nebo ne?
And the last one had a little bit of distorted consonants as well as a monotonous voice. And these patients haven't started any pharmacological treatment yet, so they're novel. And there is a distinct speech profile linked to their disease diagnosis.
Když člověk
So what happens once we start pharmacological treatment, mainly dopamine, we have not just the impact of the disease, the tremor, the rigidity, and the bradykinesia, but also we have the problems and the side effects probably coming from the pharmacological treatment itself. So we have here a patient who's off medication, Lenny.
Day job, 6-7 day a week job. I enjoyed every bit of it. I used to work 7 days a week, for 4 children.
So you could see how tremor and rigidity affects his speech because he's quite rigid and the tremor doesn't allow much of the movements to be heard. And this is the same patient, same day on medication, after he took the medication.
Grandchildren. I go to the house. One boy. The oldest is 18. The second is 16. 13, 8, 6, 3, and 1.
So if you had to vote which one is more intelligible and more clear, I mean, I think it's very difficult to say. He's definitely louder when he's on medication, but the extra movements, the dyskinesias, as we call them, do prevent the coordination between breathing and speaking and voice to happen so that he's clear enough to be heard. So it is an added problem. Then we have the natural variability of speech that we all experience during the day. Either is caused by fatigue, but for patients with Parkinson's, it can be caused by extra saliva or extra dryness that fluctuates, by posture, and obviously the stage of the disease, the other medical treatments they may have, the way they feel. So let's see if that plays. It will play for sound for sure, I hope.
When should I start?
Go.
I really don't know what to say about America, except that I don't think I want to speak about it because I can't think of what to speak about. I'm afraid at the moment I can only focus on how I'm feeling. And the problem with, at the moment, I find my biggest problem is stiffness in my left arm. And it's this stiffness that is kind of overtaking me because.
So you see, it's sometimes speaking is not what people want to do, and that's something we need to take into account when we do all these studies. And this is the same patient later on medication and on deep brain stimulation. So
There we are. All done. When you're ready, go.
Okay, this is my 1 minute speech, which I was totally unprepared, but I guess I could talk about the Sheffield Film Festival, about which I know absolutely nothing, except that Michael Francis, who directed this video of me talking about my condition, the Parkinson's, and the effect that the simulators had on it.
So you can see how much more fluent she is and more willing to talk. It's not just the pain that disturbs, but there's also the wish to talk. that can
There we are.
we feel better. So a conversation topic and partner, the space, the emotional situation is number one in most patients' reports. Background noise does affect them, sometimes for the better because they increase the volume, as in masking, and other concurrent activities, basically whether they washing the dishes at the same time or whether they've got other issues in their mind, as we all do sometimes. So the effects of medication and deep brain stimulation on speech can be varied, but the one thing that amazed me when I started is how can one treatment that is so beneficial for movement doesn't do much for speech, and why a speech motor control issue doesn't get better with dopamine necessarily or stimulation. So I'll show you. Let me see. There we are. I hope that plays because George is one of our first patients. And the one
Can you try to walk around here?
I'll describe what you see. Basically, is the first patient I had with deep brain stimulation, and he was a Shakespearean actor. As you can see, he's very stiff and had a very significant tremor. And that's before his operation, and that's him after 3 months. Yeah, okay. But you can see how even without any medication, stimulation in the subthalamic nucleus it made his gait much more fluid, and his posture more upright, and arm swing normal, but his speech was worse. So he came to me at 3 months post at that stage, and he said my speech is much worse, and because he was an actor, his speech was really better than mine. So I said, George, I'm sure you're imagining at the time when we started at Queen Square in 2002, the unit with Prof. Marwan Harris, all the reports and the FDA report were positive about speech. So there were no reports of negative impact of STN stimulation on speech. So George's complaint is what made me curious about the whole issue, and I haven't regretted it. We started a study that included all patients because up to then there were only selected patients in studies. So we decided to include every single one who goes through speech, and we've yep. Is that London? we haven't. Yeah, there it is. So we have continued to record patients post-op, and now we are probably 22 years post. This is the first big paper we published back in 2010, and the wonderful papers by Takashi Tsuboi and his group, Tanaka, are corroborating the fact that speech does deteriorate off and on medication post deep brain stimulation. This is another paper with 8 years post results on 26 patients by our group again. And it shows, for example, that when we start with almost 100% speech intelligibility, and this is the scale we measure speech, how clear speech is, how easy to comprehend it is. So you see, we start off with about 90, 87, 90, and then at 1 year it drops to 70, and then at 5 years it drops even more. And I'll show you a few examples of how speech can change. This is one of the first problems we find, that there is this dissociation between motor and speech effects. This is AA before.
This morning we got up a bit late because we like to stay in bed as long as we can. And then I managed to get to the bathroom and went downstairs to take a shower.
So you would say this patient sounds normal, bit monotone, but he's understood. He can be understood. He's an accountant with 2 children. And this is him a year after stimulation. So this is an example of how stimulation in subthalamic nucleus bilaterally affected the voicing control. You can see how he's very, very, very tight voice and a huge difficulty interrupting the voice in order to get the voice less sounds out and to breathe. So this coordination that we saw at the beginning of the talk between voiced, voiceless, breathing and pauses is disturbed with this patient. Also, you saw how when he started whispering, which was the technique we got, everything got more intelligible because we got voice out of the equation. We only needed articulation. We only do articulation for whispering is when we keep the vocal folds open for the breathiness, because I speak like that, so I don't need to vibrate vocal folds. And I leave only the articulation. And that was better because he didn't have to coordinate this voice onset time that we do otherwise. And this is him just to show you off medication, off stimulation, the same day.
Yeah. And what's your favorite food?
What
What it is? Is that the Persian omelette? Is Persian kebab?
Marinated lamb kebab. So you see, he's more intelligible, but he's such a pain because of the spasms, and that we can't. This is not an option to keep that setting. Another problem we have is the difference between simple aspects of speech and connected speech. So he can do no problem. So there is no sign of problem when he does this simple voicing, but the problem comes when it's connected. The speech is connected when we get more than one element together. Also, the other problem, and I won't play for the time issue, I won't play these 2 videos, but it's the fact that we don't have a way to predict. We didn't have at the beginning anyhow, to predict which patient is going to deteriorate and which patient is not, or is going to get even better. So initially, at 6 months post, when they come and they start complaining, they complain about how it feels to speak. It feels harder, not that their speech is worse. We can't hear anything. They perceive it as harder. And then the speech does deteriorate. So if we had a way to intervene at that stage, maybe we could prevent the deterioration later. That's a thought. The third biggest problem we have is that we perceive we have at least two distinct speech types after deep brain stimulation. So we have the one you heard with tight voicing and inability to switch between voiced and voiceless.
Okay. Then I'd like you to read 3 sentences here. Have a look. When you're ready, go.
Sorry.
Yeah.
We got married, right? Yeah. It was. I think I'll help.
So So you see, it's totally like laryngeal dystonia, inability to allow the vocal folds to vibrate in a way that allows for the normal voiceless voice onset of speech. But then we can have a really hypokinetic, marked hypokinetic effect on speech, which is why?
She was about 15-year-old who went with Parkinson chalet to rent in Switzerland. And I went along as well.
And
So this is so quiet, and the frustrating issue with this type of speech is that even I cannot make it louder. So it's a complete hypokinesia and difficulty perceiving as such, even, oops. So predictive factors, we did try to record everything pre and post, and because there were consecutive series, we found in 54 patients that the main factors that predict speech deterioration are surgical factors. So it depends on location, where the electrodes are, but millimeter difference can make a huge difference for speech. And the stimulation parameters, the voltage, the frequency, and the pulse width. Clinical factors, we have disease duration as the greatest factor. So the longest the disease duration, worse speech outcome, which is interesting because that was one of the findings in the old literature of lesions, not so much recently. And this is an example, because there is a lot of maps recently, but this is one of the first ones we got in from our group, where we plotted in with a neurosurgeon the outcome. You see, green is improvement, red is deterioration, and blue is mild speech deterioration, almost staying the same, to see where the which location is worse for speech outcome. And you see the majority of the problem is on the left, funny enough, because these are the patients who did much worse, not the ones on the right. Or when the electrode is in between the subthalamic nucleus and the red nucleus here, the rubra. But then we thought maybe, these are some of the studies that came before and after that corroborate the same finding, that this corridor in between the subthalamic and the rubra is the culprit. But then we wanted to see what exactly the role of the voltage is, whether it makes a huge difference how much we stimulate and where the electricity goes. This is a quote I like from James Rank, 1975. And I like it because we haven't really moved on much in our understanding of how electricity affects nerve system, especially deep nerve system. So he says, very, very eloquently, the phrase electrical stimulation of the lateral hypothalamus is a shortened version of the statement. There was a stimulating electrode in the lateral hypothalamus, which affected an unknown number and unknown kinds of cells in unknown locations in the vicinity of the electrode and so on. So he was quite cynical, but I think, which is easy, obviously, but it's good for us to be challenged by that. When we wanted to see whether it was location or voltage that made the difference in speech, we conducted a study whereby we stimulated patients inside the subthalamic nucleus at high voltage, which was 4 volts, outside at 4 volts, inside low voltage at 2 volts, and outside at 2 volts. And to our surprise, we found that it's not in or out that plays a role in speech or movement, it's high or low. So patients stimulated in the nucleus at high voltage were worse in speech intelligibility, so lower, than patients who were stimulated inside the nucleus at low voltage. Compare that to the motor effect. So motor, wise, the lower the better. So patients stimulated inside at high volts were better movement-wise, tremor and rigidity control, than patients who were stimulated inside at low voltage. So there seems to be a different threshold that controls speech to that controlling movement. The follow-up studies from that were with Matthias Armstrong, a bioengineer who modeled the spread of stimulation to see why that happens when we have 4 volts. Where does the electricity go? And this is what triggered quite a lot of progress later on and studies on the frequency, pulse width, and voltage spread of stimulation to adjacent structures. The theory and hypothesis behind that is if you stimulate in one place, the electricity will affect nerve conduction and pathways, cortex and subcortical links, and will change speech motor control. So we have directional steering, where we control which aspect of the electrode is stimulating the nerves to control for side effects. We have adaptive DBS and closed loop simulation, but all of this needs good patient scoring data. We need to have very, very good data, raw data for these technical advances to make sense, whether they're in imaging or electrode related. They all need proper speech data. That's why I start off always with a good speech recording. And that brings us back to how to measure treatment outcomes. We've got lots of scales, we've got lots of numbers, but we need more outcomes to do with life. Say, for example, this lovely study, 1960s, it was published, 81 patients properly followed up for the degree of incapacity, as they call it. So how many patients were employed before the lesioning, how many after, how many depend on help, and how it also had family reports here and conversation. And that's just to wrap up that despite the medical landmarks in Parkinson's and the surgical landmarks with thalamotomy, DBS, STN DBS, we still need to challenge ourselves when it comes to speech, gait, and balance, because I didn't mention, but gait and balance can worsen after DBS. Now, we're going to briefly talk about, for 5 minutes, about the main therapies we have, and the one. Let me see, because we don't have much time, and I wanted to talk about the elephant in the room when it comes to. Okay, I got this back. This back. Okay, so the elephant in the room with these landmarks, surgical and medical landmarks, is they treat motor aspects. And obviously, as we saw earlier, speech relies a lot on emotional aspects and whether you want to talk or not and who you want to talk to. And also is based a lot on this very, very, very sensitive sensory integration, the auditory feedback. So patients with Parkinson's come to me and say, I'm not quiet and I'm perfectly fine. My wife is deaf. And they all say that, every single one, because they cannot hear themselves back. So unless we target the sensory motor feedback, we won't be able to be very, very effective. I'll get to the point. We have 3 big areas of behavioral treatment that have randomized controlled trial evidence. One is non-invasive brain stimulation from the Czech group of Elina Tripoliti. Then we have singing, which has now evidence. And then we have the LSVT loud behavioral therapy. be very, very brief. The non-invasive brain stimulation is based on the right superior-temporal gyrus because this is what is supposed to be associated with modulation of prosody, melody, and sensory motor feedback. So I'm not doing much on that, but there is on your slides this main study by Lubos Brabenec and 10 days of RTMS, and the effects were very positive, but didn't last further than 10 weeks. Then we're going to singing. Singing and PD studies. Obviously, every singing group is different, and it all depends on the choir leader and the group. But, for example, in our singing group, here is an example of...
Diving into the camera. Ready? We're going to do Ramsgate, Margate, and Billingsgate. Here we go. Ramsgate, Margate, and Billingsgate. 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 Ramsgate, Margate, and Billingsgate.
And that's the next part. So it's a wonderful group that keeps running, and why and how singing can help patients. Motor drive, timing, that's the timing of voice and voiceless, but also breathing and initiation. Sensory motor integration is vital for singing, and these affective functions, the high level cognitive and affective, it touches the memories, it touches the soul, it touches everybody's. And this is one of the new videos we have, just tiny bit. I'll play just for the fun. So you can see more of that later if you want, but it's a wonderful way of getting voice out. Now, I won't go much into LSVT loud. There is huge amounts of evidence for this treatment, which basically targets loudness, as we saw on the video before. It has this sensory calibration. What do you hear? Is that the same what others hear? Increase the effort so that you get what you need to be heard. And salience, which basically is you need to calibrate the treatment to make the treatment relevant to the patient. It's one-to-one treatment. It takes 16 sessions over a month. So it's like going to the gym for voice. And it does have wonderful effects, which can spread around facial expression, so you can see people lighting up after this treatment, and articulation, intonation, but also we have very, very good studies, especially the Narayana, the recent one, 2022, for the effects on the cortical, subcortical level. So it has 5 randomized controlled trials. The effects do last. It's very good for telepractice.
Yeah.
And we basically give people a way to exercise the voice the same way they exercise their body, and with amplitude, with bigger movements in mind, in the same way and the same discipline they take the medication or do any other pharmacological treatment. Now, I hope this plays, but I doubt.
Take it away. This is what LSVT sounds like.
It doesn't show, and it's losing the evidence. But it's, as you saw before with the singing video, it's a wonderful way to combine also not just loud voice, but big movements, and increasing that amplitude across the spectrum. It comes to the face and it gets people to show their emotion more, and that always brings more conversation, more communication. Now, we don't have time to go into stuttering, but it's another big area of extrapyramidal motor speech disorders, and it's can be acquired, so it comes at after the diagnosis, or it can recur if you had a persistent developmental stutter. It can come back again after a few days, a few years of Parkinson's disease. I don't think we have time, so I may go quickly.
I
may not go into it. Just to say that thalamus plays a huge role in these disfluencies, as it was shown recently, and with this data we have, especially the Tsuboi paper is wonderful for disfluencies. 24% of patients after DBS started stuttering. So there is a link. And this is the dystonia part, which again, we didn't have time. I can talk forever, but this is the other side of Parkinson's, the hyperkinetic, the extra movements. And we can do another one for those if you want, but there is a bit. All I want to do is go to this one, the slide before, one slide before last, before my thank yous. Cross-fertilization. This is a study I found in the Journal of Zoology, Zoo and Wildlife Medicine. By chance, is the giraffe that apparently traveled a long way in Australia and got torticollis, so this kind of dystonia of the neck, turning the neck, and they gave a daily therapy to people, you see here, laser and physio, for 2 years in order to recover the neck movement. So this is just to point out that speech requires a lot of therapy, behavioral therapy and human time contact, and we need money. So this is a quote from Demosthenes, an orator from Greece who had stutter and was writing speeches for politicians instead of giving the speech himself, to say «Δίδει χρημάτων εν άνευ τούτων ουδέν εστι γένεσθε των δεόντων». We need money, and without that we cannot do what we have to do. So he's a very pragmatic man, and he cured his stutter by running up against the hill and talking in the out breath. So he putting pebbles in his mouth, and we know quite a lot from him on stutter. So thank you to all the patients, thanks to the caregivers, and thanks to my collaborators in Prague, the UCL team, and Dr. Stamelu here at here. And thank you for your patience and attention. And obviously, thanks to Steph. So any comments, any questions? Thank you.
Thank you very much. Such a shame the videos didn't play. I've seen them all, and they're really helpful to bring the point across.
Yeah.
Any questions in the room? Not yet. So I get you started with a couple of questions. So you mentioned the paper from 2015 that showed 25% of patients develop speech disorders. Is that right?
Yes. And 20 the patient these are 25% with disfluencies. So just disfluencies. Our paper from 2010,
Yeah.
the first one we had, it's 75% of patients develop speech problems post DBS. Sorry to make you dizzy now. We're going quickly back to our patient data. Yeah, so here we are, very near. Don't worry. There we are. So the majority of our patients develop speech problems post DBS. Yes. So
that's quite a lot, 75%. Is that then continuously recorded in the clinical routine that you record speech output, speech monitoring?
Yeah, so we start with baseline. That's one of the main problems we have in the literature. You do need a baseline recording, otherwise you don't know what you're comparing. And that's why I start always with a recording fidelity. It has to be really good. It's like not having a good blood test. And so you have to have a good baseline, otherwise you forget, everybody forgets. And then we're now 22 years post for these baseline patients. Yeah. It has to be done continuously. Yeah.
And at which point do you come into the clinical routine? Do you see the patients before they get DBS, or?
Yeah. Well, I see all movement disorders, but yes, the DBS patients have to have a pre-op, and then we do therapy now before. We do the LSVT before to get them as ready as possible with as great voice and speech as possible before surgery. And then we intervene depending on what their speech goes, where it goes. But having said that, when we did our first study with this one. When we did this study with the team, and we saw that the contact location is so paramount, the surgeons, because we did it with the surgeons, changed the contact location, and then after the cohort after 2010 had much less speech problems than the cohort before, and that was a wonderful example of how research can be clinically applicable as well as.
Absolutely. My phone died, so I can't check if there's any questions online.
That's fine. If there are.
Those are the difficulties when you do it live.
No, that's fine.
But so the songbirds, you said they very early in your talk, you said they learn their speech by adaptation with words around them, not like ingrained. And so that means depending on where the songbird lives, they have a different speech or dialect.
Yeah, and the same happens for all vocal learners. And this is a slide I didn't show earlier. It's to do with it's completely out of my head, and it's not published yet. But we try to organize what happens in de novo PD patients and mild to moderate PD patients, and where the sensory auditory feedback comes into place. So this is number 8, and this is the important part that is targeted in the RTMS studies as well. But also it shows how initiation is one thing and execution, but the limbic integration and the sensory motor integration are the main issues in PD patients, and in the songbirds. Where are the songbirds here? We go back. Mm.
There's a question from the audience. Let's see if
Yeah.
I can. Here we go. Yeah.
Okay, thank you very much for your
Yeah.
talk. I have some questions. So the first is, how do you select which kind of therapy you are going to apply for the patient? There is a protocol, or because you show different therapies?
Yes. So every patient is very, very, very different. So this is a great question. I start with where is the evidence and what is the problem. So, for example, let me go to the slide with the therapy we have evidence about, because I didn't show you other therapies that have very little evidence but could be useful. For example, I need to show you. Do I have time to show you masking? Do I? Maybe not. So we start here. We cannot do non-invasive brain stimulation in the clinic very easily, which is one of the main criticisms of TMS. But we do have the choir, and people can or may not join, depending on how they feel about voice. But the main one we do provide is LSVT loud, because that has a lot of evidence, first of all, and second, is effective for the majority of patients. But if we have patients with stutter, for example, let me show you these ones who have a stutter. A stutter doesn't respond to LSVT loud. So stutter is one of those challenges that I need to show you to understand. That patient here.
Who has grandchildren? And what did you used to do before when you were working?
The business, my own business. Back near Buckingham Bars.
Oh, what was it?
Snake bar.
What was it?
Snake bar. Snake bar.
Snake.
Snack bar.
Ah, snack bar.
I think he got upset with me because I had snake bar. But anyway, this was a snack bar for the Queen. And he's too modest to say. But with this patient, the problem was stimulation. He had deep brain stimulation and his childhood stutter recurred. So it came back and became much worse. But we worked with the neurologist to adjust the stimulation so that his stutter is not so debilitating. We also did loud therapy, and it made things worse because this stutter is dystonic. So it's not one thing fits everybody. This is a great example of how LSVT can make him worse. What can make him better sometimes is pacing and getting the metronome kind of therapy, which is very annoying, but that can help. And the other thing is prolonging. Another technique we've got from childhood stutter therapies, we prolonging vowels so that the system moves on, doesn't get stuck with the initial sound. So it is a very, very, it's the art of therapist really to pick what helps. We always have to bear in mind, you don't overload the system. It's like going to a shop and wanting to try everything. You have to do one at a time, otherwise it doesn't have any effect at all. And you have to have a kind of pathology in mind. You cannot just do out of it. Yeah.
One more question.
Okay. Okay, and for the stimulation, when the patients go for the stimulation therapy, how long it lasts, or there is the possibility that patients that improve in their speech then can deteriorate? Or
Yes. So you mean when they implant this electrodes in the brain. This is a chronic stimulation, so it lasts.
Okay.
Yeah. So sorry, I should have had a bit of introduction. But you're right. It's a battery, like a pacemaker, and 2 electrodes in the brain. So the electrodes stimulate the subthalamic nucleus or wherever, and the stimulation is chronic. There are different ways, but it is reversible. So you could switch it off, but most patients get too much tremor after, so it's not comfortable to switch off. But the idea is for life.
Thank you very much.
You're welcome.
Thank you. Well, thank you so much. This is
Thank you.
So I just pan you out to the room. People have to leave because we're at the end of the brain hack.
Yep.
But lovely to see you again. And thank you.
Thank you. I'm sorry it was all rushed in many ways, but it was good fun to see you all again. And thank you.
Thank you so much. Good to see you again.
Thank you. Bye-bye. Bye.
Bye. Thank you.
Bye. Thank you.